Hello my dear friends, I welcome you all to my daily dose. So I am myself DR.RAJESH GUBBA, I am the general medicine educator. So as the part of today's daily dose, here is the clinical question. So a 42-year-old female presenting to the emergency department with retrosternal discomfort. She was diagnosed with systemic sclerosis a year ago. Which of the following statement is true about the systemic sclerosis? The options are: microstomia is only seen in diffuse cutaneous systemic sclerosis. Second option, skin involvement is limited to face, hands and feet in limited cutaneous systemic sclerosis. Third option, esophageal dysmotility is only seen in limited cutaneous systemic sclerosis. Fourth option, anti-double-stranded DNA antibodies are normally detected in patients with systemic sclerosis. And fifth option is Raynaud's phenomenon occurs as a result of skin fibrosis. Now, so this particular question is basically related to your scleroderma or systemic sclerosis. So if you take this systemic sclerosis, this is mainly of two types. Number one, we have what is called limited cutaneous systemic sclerosis, and the other one is diffuse cutaneous systemic sclerosis. These are the two types of systemic sclerosis. And as such, if you take the systemic sclerosis, it is a multi-system disease. And what exactly is the cause is not known. But multiple systems in the body are being affected. And if you take in case of limited cutaneous systemic sclerosis, the scleroderma or accumulation of the fibrous tissue is just accumulated in the skin. That is, it is involvement of the skin and as well as the soft tissue. Whereas in case of diffuse cutaneous systemic sclerosis, there will be also involvement of the organs as well. That is the difference between limited and as well as the diffuse systemic sclerosis. Now, first of all, you take the first option. Like what is given? The option mainly about the microstomia. So, you take the skin involvement. Skin involvement of the face, it is seen in both the forms. It is seen in case of your diffuse and as well as limited scleroderma, but the characteristic beak-like nose and small mouth, that is what is termed as microstomia. This particular microstomia, it is seen in both the forms, in both limited and as well as the diffuse scleroderma. But what is given in our options, it is only seen in diffuse scleroderma, which is an incorrect option. Then you take the second option. Skin involvement is limited to face, hands and feet in limited cutaneous systemic sclerosis. And this is the correct answer in this particular question. So, if you take the skin involvement, it will be there in both limited and as well as diffuse. But in case of limited, the skin involvement is just seen only in the hands, face and feet. And that is the reason why your second option is correct. But whereas in case of diffuse cutaneous systemic sclerosis, skin involvement across most of the body will be there in patients with the diffuse cutaneous systemic sclerosis. And that is the reason why your second option is correct. And you take the third option. That is about the esophageal dysmotility. See, esophageal dysmotility may occur in both the forms of the disease. That is the reason why this particular third option is incorrect. And what is given in our question? In our question, it is given that esophageal dysmotility is only seen in limited cutaneous systemic sclerosis. That is the reason why it is an incorrect answer. Why? Because esophageal dysmotility is seen in both the forms of your scleroderma. Next, coming to the antibodies in these patients with the scleroderma. In scleroderma, there will be raised levels of anti-nuclear antibody, anti-centromere antibody, anti-Rho and as well as anti-topoisomerase antibody. But the one which is specific to the limited cutaneous systemic sclerosis will be anti-centromere antibody, and the one which is specific to your diffuse will be anti-Rho and as well as the anti-topoisomerase antibodies. So these are the question, or this is the option related to your antibodies. Then you take the antibodies, that is anti-dsDNA, which is given in our options. Anti-dsDNA, it is elevated in systemic lupus erythematosus, but not in case of systemic sclerosis. So that is the reason why your anti-dsDNA is ruled out. The fourth option is ruled out. And you take the fifth option. Raynaud's phenomenon results from digital ischemia, but skin fibrosis is not mentioned here. So that is the reason why your Raynaud's phenomenon is also being ruled out. So going to the question back again, microstomia seen in both diffuse and as well as limited cutaneous systemic sclerosis. Second option is the correct option. And if you take the third option, esophageal dysmotility is seen in both limited and as well as diffuse. And anti-dsDNA, that is fourth option, they are elevated in case of SLE but not in case of systemic sclerosis. And you take the fifth option, Raynaud's phenomenon, skin fibrosis will not be there. It is mainly the digital ischemia like what you see in case of Raynaud's phenomenon. So this is about the question of the day 1. Now if you take one more clinical question here, that is the question of the day 2. A 30-year female presenting to the emergency department with worsening stiffness in hands, wrist and feet. She mentions that the pain has been particularly bad in the mornings and on examination there is palpable spleen. Initial blood tests reveal a low neutrophil count and there is raised C-reactive protein. What is the most likely diagnosis in this patient? The options are Felty's syndrome, reactive arthritis, Still's disease, infectious mononucleosis and serum sickness. Now in this question I will rule out each and every options and come to a conclusion which is a correct answer. Now if you take a middle-aged female, if you take the clinical history, she is a middle-aged female and she is having pain and as well as stiffness mainly within the small joints and particularly in the morning time. So that will suggest rheumatoid arthritis, and upon that she is having the palpable spleen and as well as neutropenia. So this particular triad, that is rheumatoid arthritis, presence of a palpable spleen, then presence of low neutrophil count. This particular triad is suggestive of your Felty's syndrome. So that is the reason why answer in this question is the Felty's syndrome. Now how can you rule out the other options? You take the reactive arthritis. See, reactive arthritis, the other name of this reactive arthritis, this is also called as Retter's syndrome. Right? This is also called Retter's syndrome. And this reactive arthritis or Retter's syndrome, it is characterized by a triad. What is that? Number 1, there will be arthritis. Then there will be also presence of conjunctivitis and then urethritis. Right? Conjunctivitis and as well as urethritis. So this is the triad what you will see in patients with the reactive arthritis or Retter's syndrome. But in our option or in our clinical question, the patient has only arthritis. The conjunctivitis and urethritis is not there. So that is the reason why your reactive arthritis is being ruled out, or reactive arthritis or Retter's syndrome is being ruled out. And you take the Still's disease. That is the third option which is given in our clinical question. See, what is Still's disease? It is also arthritis, but it is a juvenile idiopathic arthritis. But what is the age of our patient? 30-year-old female patient. And in this particular Still's disease, they will also have pyrexia, rash, along with the arthritis. And usually the Still's disease, the age group is under 16 years. In our clinical question, the age group of our patient is 30 years, right? And that is the reason why your Still's disease is also ruled out. Then you take the infectious mononucleosis. Infectious mononucleosis, it is also called kissing disease. And this infectious mononucleosis, it is caused by the virus, that is Epstein-Barr virus, that is EBV, right? Epstein-Barr virus. Okay. Now in case of this infectious mononucleosis, you will have the presence of splenomegaly, but arthritis, neutropenia, they are not the features of your infectious mononucleosis. So that is the reason why your infectious mononucleosis is also ruled out. Then you take the fifth option, that is serum sickness. See, what is serum sickness? It is basically a hypersensitivity reaction to the antibodies. The antibodies whichever have been derived from the animals, if you give that into the humans will develop the hypersensitivity reaction. That is what is called as the serum sickness. And what will be the clinical picture in serum sickness? Fever, rash, arthralgia, malaise, splenomegaly and lymphadenopathy. And in our clinical question, if you see, only splenomegaly is there, but the other features like arthritis, neutropenia, they are not seen in these patients with the serum sickness. So that is the reason why your serum sickness is also being ruled out. So going back to our question now. So our patient, she is a female, 30 years. She has rheumatoid arthritis. How can you say that? Stiffness in the hands, wrist and feet, and mainly in the morning. And she is having palpable spleen, splenomegaly and neutropenia. This triad is suggestive of your Felty syndrome. And why do you think that there is raised C-reactive protein? That is because of rheumatoid arthritis. Rheumatoid arthritis is an inflammatory arthritis. So that is the reason why there is raised C-reactive protein. And all other options I have ruled out. Reactive arthritis, triad is not there. Still's disease, age is not matching. Infectious mononucleosis, only splenomegaly will be there, right? Whereas in serum sickness, you will not have this arthritis and as well as the neutropenia. So that is the reason why the answer to this question is Felty syndrome. Now, let me discuss one more question, that is question of the day 3. The clinical question here is 53-year-old man who works as a chef, presenting to the emergency department with sudden onset severe pain, tenderness and swelling of the first metatarsophalangeal joint. The pain is making it difficult for him to mobilize, and he has had 2 previous similar episodes. Blood test reveals there is raised serum urate levels. What is the most likely diagnosis? Gout, pseudogout, septic arthritis, reactive arthritis, osteoarthritis. Now, so what I will do is, I will rule out all other options based on the clinical scenario. See, our important point here is that there is tenderness, swelling of the first metatarsophalangeal joint. That itself will give us a clue that it is your gouty arthritis, right? Now, how to rule out the other options? And the other point in favor of your gouty arthritis is raised urate levels. That is another point which favors your gouty arthritis. Now, how do you rule out the other options? Now, let me discuss that. You take the pseudogout. Pseudogout is your second option. Pseudogout, usually it will present as monoarthritis. And the joint which is commonly affected in pseudogout is the knee, wrist or hip. But remember, in case of pseudogout, the involvement of first metatarsophalangeal joint is rare or unlikely. And not only that, in pseudogout, the raised urate levels, they are not seen. So that is the reason why your pseudogout is being ruled out. Then you take the third option, that is septic arthritis. See, septic arthritis should be considered in any acutely inflamed joint. Okay, fine. Your first metatarsophalangeal joint is acutely inflamed. But the point is, in case of septic arthritis, raised urate levels will not be seen in these patients with the septic arthritis. So that is the reason why your septic arthritis can be ruled out. And you take the reactive arthritis. I have discussed this even in my previous question also. In reactive arthritis, there should be a triad. What is that? Number 1, the asymmetrical polyarthritis, usually the lower limb, right? And there should be conjunctivitis and as well as urethritis. So this particular triad is not there in the clinical scenario which has been given to us. So that is the reason why your reactive arthritis is also ruled out. Then you take the other question, that is the other option, osteoarthritis. See, osteoarthritis is very unlikely to present as acute arthritis affecting just first metatarsophalangeal joint. And the raised urate levels and the clinical presentation mean that the diagnosis of osteoarthritis is unlikely. So that is the reason why your osteoarthritis is also ruled out. So going back to our clinical question, 53-year-old female working as a chef, presenting to the emergency department with severe pain, tenderness, swelling of the first metatarsophalangeal joint, raised urate levels, very much suggestive of your gout. And how are you ruling out the other options? In pseudo gout, it is not first metatarsophalangeal joint which is involved. There will not be raised urate levels. Septic arthritis, they will have fever. They will have acutely inflamed joint, but they will not have raised urate levels. So your C is ruled out. Reactive arthritis, there should be a triad. Asymmetrical polyarthritis, conjunctivitis, urethritis. So your reactive arthritis is ruled out. In osteoarthritis, involvement of the first metatarsophalangeal joint is very unlikely. And in osteoarthritis, they will not have raised urate levels, right? So these are some of the clinical questions for today. So thank you very much. So please follow us on the Daily Dose. And for more multiple choice questions, videos and notes, please download the Medicine Made Easy app, where the entire subject has been taught in a conceptual manner. Thank you very much.